Good morning, everyone. Welcome to this session in the forum. Hopefully some of you have been in this room before. We aim to deliver a different kind of session. We're not going to have lots of didactic presentations. We want to have a lot of discussion. And that means audience discussion as well. So we're going to get these microphones, and Martine, my colleague here, will explain to you how that's going to work. So I'm an interventional cardiologist in Leeds in the UK, and we've got a stellar faculty here, Hendrik Trader, cardiac surgeon from Mainz. We've got Matti Adam, who's been a pioneer of AR treatment with TAVI in Cologne, and my colleague and compatriot Mohammed Al-Khalil from Newcastle. And then Martine Gillard, who is our spokesperson. And Martine, you can maybe tell the audience here how we can get them involved.
I think we are pleased to have you, and very welcome, much welcome. So the goal is that you have to comment. If you have some comments, some questions, do not hesitate, because we are here for you. And you can ask by this way. I can send you the cube, but also you can have...
Here you go. You, my friend, catch. Tell us who you are and where you're from.
My name's Ken MacLeod, and actually I'm one of the board of directors of JenaValve, so I'm not going to say very much today at all.
Okay. We better do a good job. He's marking our homework, Martine.
And you have also the application if you prefer. So do not hesitate to ask questions, to make comments.
But even if you don't want to ask questions, you may not get a choice like our friend here, because the microphone might come your way. So be aware. If you go on your phone, we're going to be throwing microphones at you, because they can't do injuries, so we're not at risk of litigation. Okay, well, let's get into the session. So, what we're here to talk about today is transcatheter treatment of aortic regurgitation. And we're going to look at the guidelines and how dedicated devices, specifically the JenaValve Trilogy System, will define treatment. So our learning objectives are to understand the challenges of TAVI in the treatment of aortic regurgitation, to find out more about the JenaValve Trilogy System, which currently in Europe is the only approved device for treating pure aortic regurgitation. We're going to embrace the new guidelines and see what they tell us about transcatheter management of aortic regurgitation. And then we're going to dive deep into the evidence base and clinical performance of the JenaValve system. We're going to do that by basing the session around two real-life cases of JenaValve for pure aortic regurgitation. So I'm going to hand over, with no further ado, to Mac, and he's going to present the first case. Mac.
Thanks, Dan, for the introduction, and thanks for the invite. Yeah, so these are two real cases we've done recently at the Freeman Hospital in Newcastle, which is north of England. Those are my conflict of interest. So this is a 77-year-old gentleman who had an exertional breathlessness, NYHA class 2. He had a background of coronary artery bypass graft and had a recent coronary angiogram in terms of as part of his workup, and he had a patent lima graft and a vein graft to his diagonal. He has also a background of hypertension and atrial fibrillation. He's being breathless. He underwent an echocardiogram which showed that he has a severe trileaflet aortic regurgitation, which we believe was secondary to a right coronary cusp prolapse. To be fair, his transthoracic echo was not really that it's severe, and he subsequently underwent a transesophageal echo to confirm the severity. As you could see here, the jet is quite eccentric, but it's quite broad, and it's hugging majority of the LVOT. We were satisfied from our imaging colleague that this is actually severe aortic regurgitation. Combined with his symptoms, we think that maybe aortic valve intervention is indicated. In terms of the hemodynamic effect on the left ventricle was actually normal in size and function. Index was fine. His NT-proBNP is slightly elevated as 1300. As part of his workup, giving his previous coronary artery bypass graft, so we thought we will maybe do a TAVI CT to assess suitability for transcatheter approach. And as you could see here on the right side, that there is no calcium on his aortic valve leaflet. His area is 538, perimeter of 83. I've put the LVOT here on purpose because for those who continue to do conventional TAVI, conventional devices for aortic regurgitation, this is important. And this is what we have in terms of the workup. Subsequently, he went for a heart team discussion. And then I'm going to hand over to Hendrik.
Yeah, so I think we have this type of patient very, very often in our cath lab. So it's a patient with a pure aortic regurgitation. So I think the first question is for our surgeon, because for you, is it a place for TAVI or is it a place for surgery for this kind of patient?
Well, if you just look at the anatomical features, it would be a surgical candidate, would be an easy, I would say rather aortic valve replacement. There is a non-coronary cusp prolapse. That's the reason for the AR. You could think about repairing the valve, but the person is 76 years old. And that doesn't make sense, to be honest. Why would I take a risk if I implant a surgical good biological valve? Then the outcome for like 15 years is predicted, and that's fantastic. So I would not think about repair. I could think about replacement, but honestly, if I would have access to a dedicated device in this whole setting of an elevated risk patient, I would clearly vote towards TAVI, but with a dedicated device.
And what about the previous grafts, Hendrik? I mean, let's say this patient was 67 with previous grafts. Is that a big factor for you, the previous grafts, that steers you away from surgery?
Sure. Every redo is an increased risk operation, especially when they're patent grafts. But 67 then, I have to change it then, we don't have long-term data on these dedicated devices. So with 67, I would rather think first about surgery, and then if there are anatomical restrictions that would prevent surgery, then yes, go for TAVI. But with 76, totally, the other way around. This is a clear candidate for TAVI for me.
What about our audience? Can we get a show of hands who will manage this patient by surgical aortic valve replacement? No takers. 77 with previous grafts. And TAVI with a conventional device for this patient? We'll come back to this. Come on. So has everyone in the room got access to a dedicated device? Okay, well, that's a discussion we're going to come on to. So, Hendrik, maybe we can see what the guidelines tell us about the role of TAVI for patients with aortic regurgitation.
Yeah, definitely. So you all know the new guidelines have come out. And for sure, we all know that surgical valve replacement mainly, is a life-saving treatment. If you have AR in an operable patient and you operate on him, the outcome is much better than not operating on him. We have data out on that for a long time. But what we also know, and this is the reason why we're here actually talking alternatives to surgery, is that there's significant undertreatment of SAVR in this patient population. And if you just look at those who showed up with severe AR, only nearly half of the patients underwent an operation, while the other half just didn't get a treatment at the time. And if it was moderate to severe AR, it was only 20% who had access to surgery. So there is a clear need for an alternative to surgery. And this is very important because if you leave the patients with AR, you know what the outcome will be. Depending on the degree of AR, the results are very bad over time. So mortality is high if you have severe AR, but it's also elevated if you just have moderate or even mild AR. So we have to do something about this, and this shows us that in the picture of having patients so much undertreated that we need an alternative to surgery. And what are the patient groups that really profit from an alternative to surgery? And this shows it very nicely. Basically, the patients with female gender got much less access to the OR than male patients. The higher risk patients in the older age groups, the frail patients, all those did not get surgical treatment. And for them, we definitely need at least an alternative to surgery. But if you look at the guidelines, and these are the new guidelines that have just recently been published, this is all surgical indications, and this is TAVR indications. Now, if you get a closer look on that, there is still a clear indication gap between SAVR and TAVI in favor of SAVR, and we only got a 2B recommendation for TAVR, and this is still clearly restricted to symptomatic patients ineligible for surgery. And later on we're going to discuss why it is like this, and hopefully it's going to change. But at this stage, if you just look at the guidelines, this is where we are.
Yeah, it's interesting, the word, the precise language, ineligible for surgery. Interestingly, in the UK, where we're not known for kind of leaping ahead in terms of where we go with new technologies, the guidance from NICE is high risk or unsuitable for surgery. So what do you think about that, Hendrik? I mean, because there's patients, I think we've been treating AR with conventional devices for a long time when the surgeon won't operate. That's the only option, right? But what about, are we now with dedicated valves, we're going to come onto the data, in a place where high-risk surgical candidates, so you would operate, but they're high risk, now maybe TAVI is a better option if you've got access to a dedicated device. What do you think? Is it still just inoperable, or is it high risk or inoperable?
No, it's also high risk. It's maybe even moderate risk, I have to say. But because what we know so far, and we're going to go through the data later on, what we know so far, the results of the dedicated device is so good, basically, that you can look at these patients like we do looking at patients with aortic stenosis, with the exception that we don't have long-term data. So I would not, age-wise, I would not go too far down, but let's say a low-risk patient, 80 years old, to me is a clear candidate for a dedicated device. I would not even think about surgery in this patient group anymore since we have access to it. But if you don't have access to it, it would not necessarily be the same when it comes to a non-dedicated device. I would rather think about surgery first because more predictable results.
So do you think in your center, if you have a dedicated valve or a classical valve, what do you think for this kind of patient if you want to take it, to treat it by percutaneous way?
Thanks for the question. I'm Matjaž Bonc from Ljubljana, Slovenia. We have opportunity to use dedicated device, but so far in the last year we are beginning to find suitable patients, but they're not so frequent as you mentioned earlier. But we have some urgent, semi-urgent cases that were treated with non-dedicated devices like Edwards. There were some slips. We have to add another valve. Therefore, we are very cautious in picking the patients, and we are temporary on surgical side.
Maybe we can get a show of hands. Who in the audience has access in their center to a dedicated device? Okay. So let me have a volunteer. Who is treating TAVI with Aki? What are you doing in your center?
Yeah.
I believe that you don't have access in your center.
So
what do you do when you've got pure AR cases in Nottingham?
Thank you, Dan, and congratulations on becoming the president of BSIS. What we do, we write to leads. And we say we've got this patient who's got severe aortic regurgitation. We don't have a dedicated device, so we refer to the centers who've got the most experience. If we had to do a non-dedicated device, it would be an oversized Sapien or that down that route. And there are certain centers in the region that use the octa-core as well. So those are the other alternatives. I hope that answered the question.
Yeah, it's interesting. I'll bring you in. In marking the case presentations for EuroPCR this year, we could have had 3 sessions on balloon expanded valves in the left ventricle, which were used for pure AR. So, but we'll come on to that when we see some data. Yes, what's your view?
Yeah, well, just a question about the dedicated devices. I mean, there's still quite a bit of, I mean, this is a great case, right? It's a prolapse case, fits great. And you clearly, in the presentation, commented that it's a trileaflet valve. But a lot of these valves are not trileaflet. Like a lot of bicuspids have significant AI. And I'm just wondering, in terms of the population that we're capturing, that would be candidates for the JenaValve.
Yeah, well, we're going to come on to a discussion of the anatomical suitability for Jena. But I mean, Hendrik, I think I've heard you talk about this. How common is it for a bicuspid valve to have pure AR, in your experience?
Yeah, it's pretty common, actually. So I have to say also that maybe not the majority, but at least half of the patients with THE with pure AR are bicuspids. And this is not the patient population. Fortunately enough, they show up younger age, and most of them are surgical candidates. So this is why we don't have a problem there. And if it's symmetric bicuspid valve, it's even easy to repair. So it's not a patient population I care so much about. What we still see, and this is the experience we have, and maybe Matti can also comment on that, since we have now the dedicated treatments available, we see those patients, not really overflowing our ambulances, but many patients now show up, and they just haven't been presented before because there was a lack of treatment. And this is what happens, and Matthias, we will also see the same thing. Once you offer it, then all of a sudden the patients come, right? Matti, what do you think?
I absolutely agree, Hendrik, and I think it's worth mentioning that there are two different as you said, two different populations of patients. We have the younger ones, bicuspid ones, and we have an older cohort of patients that has aortic regurgitation, and those are not mainly bicuspid. And the more you talk about, it's a little bit like tricuspid regurgitation, right? The more you talk about it, the more you will see those patients, and we'll show you with data later on. I think that it's not only, as my impression is you can see picking up numbers all over the world if you have access to dedicated systems.
Okay, well, we should move on in the interest of time. So we're coming on now. I think we all agree there's a clear consensus in the room. This is a patient for a transcatheter approach. So then the question is, what device are we going to use? And it's worth reflecting on where we've been up until recently in terms of access to conventional devices. So this was a very early registry study which included 331 patients from 40 centres, retrospective data collection who were treated for a dominant aortic regurgitation. But it's worth noting when we come to the outcomes of this study that calcification was not an exclusion. And there were some AR-specific devices included. These were transapical JenaValve Engager at that time. But if you look at the outcomes, and I've highlighted the key ones in the red boxes, that we had a 3% procedural mortality. We had 16.6% of patients having a second valve implanted, and we had 10% of patients with at least moderate aortic regurgitation. So these are pretty awful outcomes. And you might say, well, this is 2017, so have we got any better? So the more recent data came from this registry, the Pantheon registry, which again was a retrospective multi-center registry collecting data on patients with dominant aortic regurgitation. But again, you'll see from my red box there that some of these patients had calcification. I think we'll all agree that if there's moderate calcification, then conventional devices are fine. And about just under 2/3 of these patients had no calcification. These are the ones that we really worry about with non-dedicated devices. And there was a mixture of self-expanding and balloon expandable. And you can see here again, there were still some dedicated devices. There were some JenaValve patients included in what they categorized in this study as self-expanding. So let's look at the outcomes. And it's easy to look at the bar chart there. TVEM is embolization. So we've got an embolization rate between 10 and 15%. And it is a horrible thing. And I'm sure many of you will experience it when you get an embolization, you know that you're in trouble. About 10 to 15% of cases needing a second valve, about 10% still having moderate aortic regurgitation, and the all-cause mortality in hospital, 5%. So this is kind of what we're looking at. Even when we kind of try to make the results look a bit better by including some calcified cases, including some dedicated devices, we're still looking with conventional devices, 10% embolization, 10% second valves, 10% residual moderate aortic regurgitation. So really outcomes that I think are not acceptable and should only be used for when we don't have another option. So Hendrik, I've clicked on, so maybe we'll move on to just discuss what, if anything, the guidelines tell us about conventional versus dedicated devices.
Yeah, and there's not so much in the guidelines though. This is the excerpt that I gave you here. So the guidelines give TAVI overall just a 2B indication, as we just discussed. And if you go into the topic of non-dedicated versus dedicated devices, clearly the use of non-dedicated devices is turned out to be off-label due to the increased risk of valve malpositioning and residual AR. So this is nothing you would really go for. But the dedicated devices appear to minimize the risk of valve migration and residual AR, but they come up with a high pacemaker implantation rate. But also this is questionable. So at the time the guidelines came out, the Align AR trial was published. So they knew the data. Still, they only gave it a 2B indication. That may have also something to do with the fact that those non-dedicated devices are not really available for all of you. Maybe that was one of the reasons why they did not increase the indication here to at least a 2A. But this is, of course, going to change in the future. And I'm 100% sure with the next edition of the guidelines, we will see an easier indication with the use of dedicated devices. But this is what the guidelines say today, and the only thing we can present you.
Yeah, I mean, I did ask Fabian Praz about this actually, and he said exactly what you said, that they didn't want to say that you should only treat AR with dedicated devices until those dedicated devices are available to the whole community, because they didn't want to say, look, you shouldn't be treating AR unless you've got these devices, because obviously sometimes patients are inoperable and we need to. But maybe Matti, we can come on to you, because and you can show us why dedicated devices make all the difference with some of the data that might apply to a max case.
Absolutely. I think the biggest difference with the dedicated device is my heart rate. And that's all what's missing in these tables from the Pantheon trials. My heart rate is definitely above 100, 120 if I do non-dedicated devices and non-calcified annuli. And I hope I'm not the only guy. But so what is special about the dedicated system we're talking about today, the Trilogy system. I mean, the item that stands out, obviously, are these 3 locators. And the locators are supposed to go into each designated coronary cusp. They will help you with deploying the valve absolutely coronary or commissural aligned. They will help you in preventing dislocation into the left ventricle. And once you deploy the valve, they will also form a seal and they will also hold the valve in place. So the trick is the 3 locators and the self-expanding stand frame will work together to prevent dislocation and also give you better sealing. And we'll see later with Mac that there are certain things you can do with the delivery system, with the valve itself, and the steps you will go through is you will first, while only the locators are exposed, you will first align the valve with the native cusps. Then you will go forward, advance the system, interact with the native leaflets, and then deploy the valve. The system is fully has full rotation, so you can actually actively commissural align, which is very important, of course, for this. The study that has been around, we mentioned it already, has been the Align AR study trial. And this is a slide from actually the just recent publication yesterday from Lancet, because the study was designed as a multi-center non-blinded single-arm evaluation of patients with AR 3+ and more. And it looked at 30-day primary safety and 1-year primary efficacy endpoint, and it had continuous access. And that's important because we were talking about my feeling about picking up the speed in which I see those patients with AR. You can also see that in this study. It's 180% in the pivotal trial population and 520 continuous access population. So I think that's an important thing. The continuous access was so fast that now we're talking about 700 patients with a 2-year follow-up. The patient baseline characteristics are shown here. I mean, it's a very typical population. I think it's 79-year-old population with 45% female. SDS promised 3.8. They all had a little bit of history of AFib, and there was left bundle branch and right bundle branch block quite commonly. And I think maybe we can touch on this later with the pacemaker issues, something that I think is important. AR severity was obviously severe or moderate to severe, and the mean annulus perimeter was 80. So I think it's on the upper end of what you'd think in terms of perimeters, but very doable in the with the system, obviously because it was the trial. Technical success rates were strikingly high. I mean, technical success during procedure was 95% almost, with a device success at 30 days with 97%. Good hemodynamic performance, gradients below 20, 100%. Moderate or severe AR or PVL, 0.5%. So I think really, really promising results with a procedural death of 0%. I mean, and again, talking about heart rate while performing non-dedicated devices, I think that's very reassuring what we see here. As we now have access to two more follow-up and to 2-year data, you'll see mean aortic valve gradient, effective orifice area, and PVL are consistently very good over 1 or 2 years with almost no moderate AR, which is also in contrast to non-dedicated devices. I'll just quickly show you the primary safety endpoint at 30 days again. Why am I doing this? Because there's something important that we can learn from this slide and the next slide. New pacemaker implantation, for example, overall was 21.6%. Let's take this as an example and move to the next slide. Sorry. You'll see that you have different endpoints on the bottom left. Primary composite endpoint, new pacemaker, any bleeding, any vascular complication. And you have the turtle, like the recruitment or the enrollment over time in turtles on the right-hand side of the screen. And you will see that significantly over time with recruitment and experience, all of these endpoints came down. Vascular complication came down, bleeding came down, and especially pacemaker rate came down from 26% to 16%. So there is something we can learn here, and I think we can also improve techniques with these dedicated devices. Again, is already significantly shown in the slide before, but the procedure date is actually affecting the predictors of new pacemaker, as of course is right bundle branch block, and the large valve sizes. So much for the dedicated data from the ALIGN trial.
Yes, so congratulations. So I think we saw that with all this result that there is a place for this dedicated valve if we compare the complication presented by Dine just before. So I think it's very important now to go to the result of the case.
Yeah, no
what
pressure
do you
here.
do,
No
Mark?
pressure at all, yeah. So, yeah, as you all discussed, we went for the MDT discussion, we had the chat, and we thought that probably percutaneous option with large trilogy valve, 27 millimeter, will be the right thing. And I share the heart rate bit with Matty, exactly. You know, prior to the trilogy, your heart rate will go through the roof. You are with your bodies on a speed dial because you know that the valve could embolize. So basically what we've done, this is the setup, how we do it. Basically, you have a right radial, right femoral, and you put a 2 pigtail. Usually with any TAVI device, we usually put it in the non-coronary, but with this, you need to really align the annulus and understand particularly the anatomy. So we put another pigtail in the right coronary, and you try to delineate where exactly is the annulus and try to understand each of those cusps. And from there, basically, you put a long sheath, which is a curved sheath, and you could see it up all the way to here. So you could see the sheath here, all the way, and goes all the way down to the femoral. And from there, you insert the transcatheter device. You could see the locators here, and it is important to screen those to make sure that they are not bent. Now, I'm sure you all had a lot of experience. I haven't seen it. Dan, have you seen it before? Have you seen it, Matty, without those bent? But it is a good practice to screen this to make sure that actually, what happened here? Sorry. So go back. And you screen it. And then from there, you bring the device and you line up the sealing marker of the device with the sheath, and then you track the sheath back to the descending aorta. And now that will open the locator slightly. And this is the first step, how we do it. We're still high up at the STJ junction. We're quite far from the annulus, and this is the first step. From there, we will push the controller slightly in. And by doing this, the locator will open more. You could see it now. The locator are now far more spread than before by advancing the locator. And subsequently, what we need to do, we need to make sure that those locators are actually aligned anatomically with the cusp. So we need to make sure that the right cusp is actually at the front. And what we need to do then is doing an RAO sweep, so the front locator will appear anteriorly. And this will give us confidence that actually we are aligned within the anatomy of the aortic valve. And subsequently, we slow advance the controller until we are above the cusps. And historically, when we do this with any dedicated valve, you will be really, really worried. This is very controlled environment. The patient is completely stable. The operator is completely stable. There's no issue so far. Everything's under control. Everything could be done again. There's no problem. Now, the most important part is we need to make sure that each locator are actually at the right cusp you want it. And that's where you have to use probably different catheters. So this is a multi-purpose. And here you could see that the locator is exactly at the none. So we are confident we are above the none. Subsequently, we check the left, and this is a good confirmation. We engage the left coronary. You could see exactly the locator again at the bottom of the left coronary cusp. And the last bit, which is sometimes challenging, is the right. You could sometimes engage the right coronary artery and then trying to slip the catheter in and trying to check. And again, you will be happy here that actually I am engaging with the right coronary cusp. And from there, you could potentially check the depth. But the most important thing here is you deploy it under rapid pacing. And it's literally like this. And you could see sometimes the cath lab team saying, oh, having that gasp like, oh God, what's going to happen? Because they are familiar with AR cases that things could potentially go wrong. And then the final check angiogram. So as the guy said, you know, the good seal, the actual intrinsic leaflet, they act as a sealing mechanism plus the actual skirt. So this patient did angiography quite well. He was keen to go home on the same day, and I had to stop him from going home. I just thought it's too much, to send him home on the same day. We sent him home on the following day. He came back after 3 months for his echocardiogram, and this is exactly what's happening with the echo. No AR, maybe trace of AR, you could see it just a whiff there, just for the keen eye, but significant clinical improvement, which I think we've seen in the Align AR data. It's much better clinical symptomatic benefit than aortic stenosis patient in terms of KCQ. All right.
So, Mac, great case, beautiful result, perfect, which in our experience it is every time. But I think I'm right in saying this was your first case. So,
yeah.
Tell us about how it was doing this for the first time. Was it challenging to do it? What was the kind of response of the team and the operating team and the rest of the cath lab team to your first ever JenaValve case?
So so that is something probably I should declare. This was the ever first case I've done myself and at the Freeman Hospital. Historically, we've always been concerned and worried about AR. As I said, there will be 2 or 3 operators on a speed dial that there's an AR case happening in the cath lab. Things could potentially go wrong. We need actually probably a self-expanding. We use it with Evolute, and then probably you have to have a backup with an Edward to slip it in. And always all these going in your mind. We walked in there. To be honest, when we looked through the process, how we do it, you'll be like, well, it looks like straightforward, but I don't know how exactly it will be inside the cath lab. But I have to say, it's a very well-controlled deployment. There's literally, I didn't actually felt at all that there's an invasive procedure. The cath lab team were very impressed with how things were because it's very controlled, everything stepwise. You could see Dan particularly proctor me on this case, and he was telling me, go left, go right, check this, check that. I literally was a puppet just doing this and doing that. So it wasn't difficult for me. And the end result, to be honest, when we deployed, I wasn't looking at the valve, I was looking at the actual deployment, which I think is the right thing to do. So when you deploy it on the rapid pacing, and then you look, you'll be like, wow, the valve is already in. I missed that. And actually, that's what it should be. You should focus on how to deploy it, and you will miss the valve deployment. And your team will be very happy with the result at the end, because you don't have to get another valve. You don't have to faff around with cardiac, CPR, all of this. So yeah.
So Mac, we have a
couple of questions.
A question here. Yeah.
Yeah. So wonderful case with excellent results. So I just wanted to know whether do you use echocardiography during the positioning, or is just only the fluoroscopy which you use? And what was the time duration for the usual procedure? How long does it take?
Yeah, very good question. So we don't use echocardiogram. We use only fluoroscopy. That's at least our practice. I think maybe people might use TOE or might use transthoracic. I've seen some cases people try to see, they grasp the leaflets actually. This case particularly was relatively straightforward. It was my first case, but we've done it within 35 minutes. I think that was done from the start to the end with deployment of the valve.
Another question here. Just to come back briefly, I think on the TOE, it's fairly common practice in North America. From my perspective, Matty, you've got the most experience, it's completely unnecessary. You can do it very controlled with confidence with fluoro guidance.
Well, absolutely. You can use TE if you want to be sure in a very exciting case and, a lot of prolapse or difficult anatomy, maybe a little bit of bicuspid in there, yes, no. And so in cases like this, when it's really challenging, TE is an option, but we never use it actually.
Another question here.
Yeah. Are there any concerns about not being coaxial? Like, for example, vertical annuli, et cetera, Because ideally, yes, obviously, you want those to engage symmetrically, correct?
Yeah, I think that's a good setup for the next case. Yeah. Exactly right. So I'll hand over to Dan.
This guy
is on. So yeah, there is concern when it's actually...
it's a great question, and that really nicely leads us on to the next. We've got one more comment before we deal with that, Martin. And then we're going to move on if that's okay.
It's really very interesting case. Regarding the pacing rate is high, what's the reason? Is it because of the interaction with the conduction system, or?
I think from the surgical data we know that about you, Hendrik. You go for it.
This is a good question, actually. We cannot answer that question completely at this stage. We know also from surgery that pacemaker rates are higher in AR patients compared to AS patients. We looked at when the first pacemaker rates have been coming out. Of course, there was concern. We looked into all the CT-based morphology data. We did not find yet that sign that shows us. But then, as Matti showed, a long time was changing a little bit the procedure, changing the degree of oversize, not pushing so far again to bring that valve deeper as it's supposed to be. And then we came back to a 15% pacemaker rate these days. So that is still higher than we used from TAVI. It may have something to do that very often, as we've seen in that last case too, the LVOT is also stretched due to the degree of AR patients have, and maybe the stretching of the LVOT and of the membranous septum is a prerequisite for higher pacemaker rates because the conduction system is also stressed already before the procedure. This may play a role, but I can't give you the final answer. Maybe Dan, you can. I don't know.
No, I mean, I think AR patients we know have a higher pacemaker rate, as you said, and there is relative oversizing a little bit more than the average self-expanding device. But interestingly, the data analysis so far don't seem to indicate any association between oversizing and pacemaker rate, or indeed depth of implantation. So I think
that's a very great point, and I just want to say exactly, we don't have evidence that oversizing is actually affecting this. I mean, we have been coming down a little bit in the sizing algorithm with oversizing, and we have improved pacemaker rates. But if you look at very detailed, it's not the oversizing, it's the bigger valves that have higher pacemaker rates, and it's the most stretched annually, and it is the patients with right bundle branch AV and left bundle branch block. So I think, to Hendrik's point, I think that might be a good explanation. For example, as in TR, the more stretched out we have with these regurgitant valves, the more stretched out we already have the anatomy. Maybe we even affecting the conduction system through that dilation so much that we have higher pacemaker rates.
So I think we should move on, yeah. I mean, so I think we've seen a case which would have been a complex case with a conventional device, but actually anatomically was pretty favorable for JenaValve. But we know that patients with aortic regurgitation often have very complex anatomy. So Matt, let me hand back to you for your second case. I don't know if this was your second ever case or your third.
Yeah,
but
the second one actually. I think
maybe,
it was on the same day.
Maybe one was a bit more challenging.
It was on the same day, I think we've done those. So not always it's nice anatomical. So this is a second case to touch on complex anatomy. This is a younger patient, 74, lady with recent admission of heart failure, and she was transferred from a district hospital. She had underwent transthoracic echocardiogram, which showed that she has a severe trileaflet aortic regurgitation, which is secondary to a very large ascending aortic aneurysm. She has a background of hypertension, hypercholesteremia, but she was relatively frail. And this is important for the decision making, which we're going to discuss. This is her echocardiogram. As you can see from echo, actually, the aortic root is quite dilated. Her regurgitant volume was measured as 127 mil. That is severe, is more than 60. Although her pressure half time is in the moderate range, she did have severely dilated left ventricle with impaired function. Her NT-proBNP was okay prior to her procedure, and that is to reflect that well-diuresed patient. She underwent her CT TAVI, which showed good transfemoral. Again, you could see there's a gap during the stretch of the aorta. Importantly, the non-coronary cusp is relatively small compared to the right, which I think it will come into what we've done during the procedure. And she has a very large ascending aortic aneurysm. I think it was measured 5.8 centimeter. So she was discussed in the MDT, and I will ask Hendrik, what would you have done? She's 74. You haven't seen the patient, but I just need to emphasize that she's frail.
Yeah, well, first I have to say, why didn't she show up earlier? I mean, this is really sad because, this degree of AR is really tremendous, and with earlier treatment, that would be maybe an easy operation. Now she has 38% ejection fraction. She is very frail. But anyhow, I mean, this is, and I'm a surgeon, so I have to apologize for not jumping right away into the TAVI business here. With this root dilatation, and this was not ascending aorta dilatation, it's aortic root dilatation, right? And we have a 58 millimeter root here already, and I think the ascending might be even like 7 centimeters already. It's a dramatic. I would first really check every option to do a nice Bental on her. That solves the problem, because just placing the valve on such a dilated root, that carries a risk that the root pathology is ongoing and that the patient unluckily comes back with type A dissection at a certain time. So that would be my concern. But of course, if she is inoperable or very high risk for surgery, then we could do something about it and just place a valve. But forgive me that I, feel intrigued to operate her the way we would usually do.
You're not a fan of I said the smash and grab surgical approach, just replace the valve, leave
Well, that is stupid. I mean, why should I, if I would just do surgical valve replacement, then I'd rather do target with a dedicated device that's much lower risk and not put the patient on a lung machine, arrest the heart and all that. So that wouldn't make sense. If I treat that patient, I treat it properly with a Bentile, and that would be my solution, right?
Maybe we can, Martin.
Okay, so in the audience, who treat this patient by a percutaneous way, and which valve, if they have no a dedicated valve, use in this type of case? So who treat this patient with a percutaneous way?
Let's have a show of hands then. Sir, you haven't met this patient, but frail, surgery? Hands up for surgery? Yeah, there's a few there.
Okay.
And transcatheter with conventional device?
I think it's the answer is very clear.
We eradicated that
nobody
option.
from. Do you want to comment this type of case?
Yeah, no, absolutely. We would be using JenaValve here, and we've used 10 now in our patients with pure aortic regurgitation in sarcoidosis. But obviously, I'd agree with Henrik that you've got to make sure that surgery is not an option, because clearly, she's got a dilated ascending aorta. But if you have thoroughly explored surgical options, then absolutely transcatheter is reasonable, and JenaValve is absolutely the correct treatment. Can I just ask a question whilst I've got the box? And it's really about deployment. And I was at the meeting earlier in the year, and the question really is about deployment and burst pacing. So I noticed that Mac used burst pacing, and I just want to hear Matty and Dan's view, and Henrik, what they're doing regarding deployment. I always use burst pacing, short run. I think it keeps things stable, but I'd like to hear your views.
Well, to be honest, I only use accelerated pacing, heart rate 120, 130, 140, depending on how good the pressure reacts to pacing, but usually it's 120. I'm a bit weird because I keep pacing on while I move the system out of the valve. I like this because I'm under control. I'm focusing on getting the system out of the delivery system out of the deployed valve, so I can focus on that. Then I turn pacing off, and then if I have 15% pacemaker, if I have something low heart rate, I can then take care of that after I move the system. So that's my workflow. I just, I'm the guy who does one thing at a time. I really like to be controlled in that. I think you don't need rapid pacing. I think it helps. I think accelerated pacing also does the trick. It's a self-expanding valve, so you would think that would be sufficient. But I mean, I think the answer is whatever works best for you, right? Dan, how do you do it?
Yeah, I mean, I don't think you need fast, rapid pacing. It's an instantaneous deployment. There are other systems that are deployed rapidly. Accurate was similar in some ways, but it's so much faster and so much more stable. So, I wonder whether we need pacing at all, but we do pace at about 120 usually.
That's a great question. I mean, we should. After the session, we should try. Okay.
Yeah. Listen, we should move on, but I think because this case is about complex anatomy, and Saga has said, and we would be exactly the same, and this is why we always say with JenaValve, with these horrible cases, when they say this is a tough case, but we say, yeah, but it's still by far the best option, so we're going to do it. You're going to help us. This case, would you take this case on? And we had the question from our colleague over here from the US, what are the anatomical factors that mean maybe it's not possible? Canada, sorry.
Canada, okay, that's an important difference. Well, I think we would definitely do the case if, heart team discussion is interventional option, we would go for a dedicated device. I think there are some considerations with that, interaction with the root, where do you put the sheath, where you pull the sheath back, all that. But I think hopefully shows that this might be a very doable case and that we have a good result in this patient. Things we might want to not tackle right now are supercalcified bicuspids. It's a valve that's designed for a tricuspid aortic valve. And while we have done quadricuspid and bicuspid, I think it really depends on the anatomy of the valve. So you want to have interactions of 3 locators with 3 cusps. And I think that's important. We can push further after we settled this, but right now, I think that's my considerations to that.
And there's, I guess, size, that's the other thing, so the maximum perimeter is 90. I mean, don't know where you've been to, we've been to 92, so that's about 28.6 millimeters by perimeter.
Yeah,
so we
important point.
We need and we will get a bigger device, but that's maybe another point.
So I will have the information about Matti about what happens for the real life, and I'll do a registry, I'll do some data about in the real world, not only in Align AR.
All right, let's see if we have something there. Surprise, we have, but I'm not sure if I include Mac, because if that's a second case, given the trajectory, I'm not sure what his 50th case will be. So I'm not sure if he can be in the registry. So what we did is Align is a super controlled setup, core lab, screening committee, and that's great because these trials will help us push the guidelines, but also on the other hand, I think we need to document and show what we do in real world, in real life. And what we did is we put 8 European centers, all super experienced, together, and we collected 360 patients with pure AR, and you can see that the baseline characteristics actually fit the Align trial pretty accurate. I mean, our patients are a little bit older, but overall, I mean, it's clearly a high or a pure AR with severe AR population. To be honest, technical success in our patients, and there were some crazy cases in this registry, I can promise you, technical success rate is 98%, so it's a really high rate of technical success. We had second valve implantations in centers that were beginning, centers that were super experienced. Overall in our clinical cohort of 360 patients, 0.8% if you compare that to the non-dedicated devices. I think that's a huge difference. Vascular complications were low with 5%. Stroke rate was also very low, 0.6%, and mean aortic valve gradient and aortic valve area were favorable. We had overall permanent pacemaker implantations of 22%, but a little higher than the last cohort of Align. But again, I think this is due to the complexity of our cases. Mortality stayed low over the follow-up. We had follow-up a little bit more of 3 years from some of the patients. But overall, the best endpoint, I think, in terms of the most patients was 1 year, and the aortic valve area stayed above 2, mean gradient stayed below 4, and you'll see there's technically no moderate PVL, no moderate AR after 1 year and longer. So I think those are very promising results. So 99% less than moderate. And something I think is super important to touch also is the improvement in functional class in these patients. As we discussed aortic regurgitation, we sometimes wonder about symptoms. It's not as clear as an aortic stenosis. It's not shortness of breath so much. It's not angina, it's not syncope. These patients need a little bit more of questioning and a little bit more of interacting with them to understand if they're actually improving. So KCCQ and all this is super important as well. But also, these patients with dyspnea, they improve a lot. So New York Heart Association class 1 and 2 in 85% of our patients. So I think overall we can say even in a real-world cohort, the treatment of AR with TAVI is challenging with non-dedicated devices. But yes, if we have dedicated devices, I think we have a very good outcome.
Matti, thanks. And that's the first time those data have been shown, I think I'm right in saying. And
absolutely, yeah.
We were lucky enough to contribute our learning curve to that. Our first 25 cases, I think, and there really were everything that we did, all the horrible anatomy. So I mean, before we go on to the case and we see how Matt got on with this pretty nasty case, it is a transformative difference. It's a tenfold change in the bad outcomes, right? Less than 1% embolization compared to 10% at least, given, because there were some calcified cases in that, and we saw with the non-calcified it was worse. How do we get dedicated devices out there? Should every center that does TAVI have a dedicated AR device, in your opinion? Or do we need to have referral centers? Can the procedure be done if you're doing 10 or 15 a year, or do you need to be a high volume? What's your perspective on that? Because to help the whole overall population of patients with AR, we need to make this technology available to all of them.
Very good question. I mean, being a high volume center, I might be biased a little bit, so take this with a grain of salt. But I mean, the guidelines give a little bit of advice on heart valve units, heart valve centers, how we should structure our vascular heart disease programs or our structural programs overall. I do think that if you're a low volume center, you should stick to the valves that you know best. If that's a dedicated system, then I think it's good. But overall, I think we should work together and find centers that have experience in those dedicated devices and then build a referral network around that. So, I mean, there's always a good correlation between the numbers you do and the outcomes you get. So I think also here we have to keep that in mind, right? But again, being a high volume center, I might be biased on that, right?
Hendrik?
Yeah, I think I have to challenge you a little bit with this, Matti, because I wish we had that discussion about mitral and tricuspid therapies. Yeah, I'm a clear fan of dedicated centers who deliver best perfect quality. But here, I mean, we've done several hundreds of cases now. It is, after a while, just a regular TAVI procedure. And the risk profile is so low, so that I cannot find arguments why not every, let's say, TAVI center that is a proper TAVI center should do it. I don't even necessarily see the need for cardiac surgery on site because nothing is happening there. So to me, it's a bit different. I would say once that is out, there's a little learning curve, but it's not much. We send our proctors around and then you learn how to do it. I see this in all of your hands when the company is available and able to produce as many devices as are needed. But I see this really coming. And then maybe one more point, and we are in an AR session, but if you use it just for pure AR and non-calcified AR, you would not see so many patients right away. But you can use that valve in every patient who has predominant AR but calcification. You can either use it in aortic stenosis patients. It's a very good valve for stenosis when you, for example, have low coronary offtake, because you will never see a coronary occlusion with a JenaValve. So if you want to use the valve more often, you can use it even in stenotic cases, in tricuspid cases, of course. And then you go from there. So I'm not so much pointing
I'm not
that
going to
same
challenge
direction.
you on this opinion. I'm happy to support everybody who wants to do this valve because it's a lot of fun. And I just want to, a little bit follow up on your point of aortic stenosis because it's a great point. I mean, you have by definition commercial alignment. We did a series of cases in the beginning, and the pacemaker rate, for example, is in the aortic stenosis patient with this valve is low single-digit numbers. So clearly, aortic regurgitation is different from aortic stenosis. We do see consistently low gradients in aortic stenosis as well. So, I mean, once we, I think, have used this device as a dedicated device for AR, there might also be a trajectory to push this even further in mixed disease and maybe even aortic stenotic cases.
Yeah, that's great. And I have to say, I'm going to side with Hendrik as well. I mean, I think, this is what I find with this device is there are more steps, but it's so controlled and so predictable, and you get a perfect result every time. So I think to get to the patients, I mean, like Hendrik, I wish we had referral centres, and we have some centres like Nottingham who refer patients, but we also have plenty of centres. I know centres in London, they won't refer them up the road. They'll do it with a conventional device. So I think our best way of helping the overall population is to get this device into every centre if we can.
Okay,
Martin,
so
you've got another comment before we see the case.
Yeah.
If I could just offer an opinion on that. We've done 10. We are one of the 35 centres in the UK. And I have to say that I think that it's really important, and I would agree with Dan and Hendrik that this ought to be available in every centre that it's doing, a sizable number. It's relatively easy technology to use. It's not really super complicated. And I think there's a horrible disease amongst cardiologists that we are reluctant to refer to other centres. And if we want to remove that obstacle and get patients treated, then we must make it available. So as soon as this technology is scaled up, as it soon will be, then it must be made available to really every centre that is doing TAVR, in my humble opinion.
Great.
So Martin, on that note, shall we see how Matt got on with his second ever JenaValve or third with this horrible case?
Yeah, Sagar, hold that thought with this case. I'm not sure it's always straightforward. So anyway, to go back to the decision, so the patient was seen actually by two surgeons, and she was turned down for a frailty reason. They felt that it's too much high risk. It's probably, one of them said prohibitive risk. So we agreed to go ahead with the transfemoral with the Trilogy medium 25 millimeter. Now, unlike the first case, as you could see here, there's a significant AR, but we, despite all our effort to delineate the cusp anatomy, we weren't able to get this right. We tried right radial. We had to get bifemoral access. We used different catheters. And I have to say, we weren't able to get where we want to do. So that was the first challenge we had, is we don't understand exactly the anatomy. We have an impression that, look, it probably is a vertical kind of annulus, but we couldn't particularly see the none. And this was the really challenge. We think all those catheters are sitting in the right, which we've seen actually on CT. It's relatively large, but we couldn't really appreciate the none at all. She has no option. She's not a surgical candidate. The team are already ready. We had a brief discussion. I said, you know what, sod it. We're going to do it anyway. So here we go. I'm not going to go through the same step. So again, you put a long sheath, 18 French, you pull it way back, you advance the controller, and then you'll advance it further, and there you can see the locator now is open. And what we've done, despite all our effort to put the catheter in each particular sinus, or cusp, sorry, we weren't able to appreciate the none. So what we've decided to do is a sinus injection to try to understand a bit more, hoping that the valve actually would separate those. And despite the effort of advancing the controller, we were not really aligning the valve properly. And as you can see, the aorta is relatively horizontal. So what we've done with this time is we advanced the actual delivery system rather than the controller. So we pushed on the whole system and the wire. And as you can see now, the valve is actually hugging the outer curve. And now you start to appreciate that the aorta is actually more horizontal than when initially checked. And from here, we start to appreciate actually where the annulus might be. And from there, we thought, okay, well, now we start to win. Now we start to understand the anatomy a bit more. We probably will be able to appreciate all the cusps. So from here, I'm sure you all agree, you could appreciate the left. And as you could see, the valve is literally horizontal. So we got one cusp, we need to get the other two. So what we've done, we sweep into the isolated left, and we were able to separate the right from the none. And we were able to appreciate that this will be the right cusp. And with the same technique, we sweep to the none, to the isolated none, and we've checked again, and we were comfortable that this is actually touching the base of the none. From there, we check the implant depth. At that point, we were pacing on the Safari wire, and I'm sure you could see here, there's a temporary wire going in. So on that particular occasion, the pacing failed, so we had to put a temporary wire. And I'm not sure whether you remember that case, Dan. Even temporary wire was very difficult to implant. And the rest is deployed under pacing. I was literally worried that this valve will go up into the aorta. And this is the angiogram.
Yeah. I mean, I was there.
Thanks for the help.
I feel a bit ill just watching it back, but this was the second case, and I think
on the same day.
What I'd also say when that conversation about you might say, well, you shouldn't be doing this case unless you've got an expert. And obviously, you had me there as a proctor,
right,
but actually, you get incredible support from the company, and this was a tough case. We had Malta, the most experienced field clinical specialist of JenaValve, doing this case, and so he helped us to kind of navigate the challenges and get, as we always do, a perfect result. So, Martina, I think we're running out of time, unfortunately.
Yes, I think I hope you enjoyed this session because we learned a lot. We know that aortic regurgitation is not so rare. There is a rate of 10%, but also valvular aortic disease with predominant of aortic regurgitation. So with the conventional valve, it's difficult to treat this aortic regurgitation related to the difficulty for the anchoring the valve and the rate of paravalvular leak, as we show in the data. So for me, the place of this dedicated valve, which seems so easy to use if we learn to be expert, it will be a great advance for our patient and allow us to treat by a percutaneous way. So. And I am very happy, and I would like to thank all our experts, Dan, which is a pleasure, and you, because your interaction. Unfortunately, it's the end, but you can ask a question to the experts just now. Thank you so much. Thank you.